Hello, everyone. Welcome to Nutrition Research Roundtable Q&A. I hope you enjoyed the keynote. Thank you so much for joining us today. We have a great session featuring some fascinating research. My name is Melissa Schiffman, and I'll be moderating this session. I'm an adult living with cystic fibrosis. I live in New York City with my husband and 2 kids. So when I was growing up, my CF was considered mild. I had annual sinus surgeries, but my lungs were okay, and I was pancreatic sufficient. In fact, I was overweight, while my brother struggled to gain weight. We had tons of high-calorie, high-fat snacks for him that I was told not to eat. This led to my having body image issues and patterns of disordered eating that I still struggle with today. Recently, I took part in writing about body image with other adults with CF in C-Fresh's Sexual and Reproductive Health Guide written by patients for providers. You can find that chapter in the resources section of ResearchCon. So even though I am pancreatic sufficient, for years, my biggest issues with CF were gastrointestinal in nature. So I'm very excited to hear from this panel of experts today. I'll be introducing the speakers before each one presents. But before we get started with the session, I want to go over a few items related to the technology and how we can all interact. First, closed captioning is available and should be showing automatically on your screen. You can hide these subtitles or adjust the view by clicking the CC icon at the bottom of your screen. We will be taking audience questions during this session, so please submit your questions at any time into the Q&A box, not the chat, the Q&A box. We won't be able to answer questions about individual diagnoses or treatment plans. We do encourage you to use the information you learned today to have conversations with your care team. Otherwise, we will do our best to answer as many questions as possible verbally, and we will also be trying to answer questions by typing answers directly into the Q&A box. So check back there if we haven't answered your question. You will also notice the group chat for everyone who is in this session. Please note you'll want to change the chat drop-down menu so that your messages go to all panelists and attendees. That way, everyone in this session can see your comments. Even though I know this, I keep messaging all the panelists and the audience does not see what I have to say. So make sure you do that. So if you have any technology problems during the session, please return to the event homepage and click the live support chat icon in the bottom left of the webpage to connect with tech and program support. I would now like to introduce our first speaker. Dr. Zachary Sellers is the Associate Chair of Research in Pediatric Gastroenterology at Stanford University and the Director of the Stanford Children's Pancreas Program, where he specializes in the clinical care of children with CF. His research is centered around improving the gastrointestinal, pancreatic, and liver health of those with CF. Welcome, Dr. Sellers.
All right. Thank you, Melissa, and the organizers for the opportunity to speak today. And of course, thank you to all of you who are participating today in ResearchCon. I have no conflicts of interest to disclose, but I do want to recognize those organizations that fund our research, and those are listed here. Nutrition has always been an integral part of CF. Dorothy Anderson, a pathologist in New York, first described CF in 49 children who had severe malnutrition. The pictures on the right are from her original paper. In panels A and B, you see 2 children with typical signs of severe malnutrition: skinny arms and legs and protuberant abdomen. Upon optimizing nutrition and/or feeding raw pancreas, this malnutrition improved. Panel C shows the same child as panel B, except 1 year later after nutritional intervention. Now you see a healthy looking child with appropriate muscle and fat composition. Fast forward nearly 60 years, and a Danish group described that CF individuals with frequent lung infections and worse lung function lost weight. This data suggested a relationship between lung function and weight. Since then, many of us have become used to seeing graphs like these from the CF Foundation registry, where lung function and weight, or BMI is listed here, have a positive correlation, meaning higher lung function is observed in those with higher weights and vice versa. This has caused some to take the simplistic view that higher weights will result in better lung function. However, it is more complex than that. More calories and more weight does not necessarily result in an improved lung function in every person. What we do know is that some, but not all, individuals with CF have difficulty absorbing nutrients. And some, but not all, individuals will have increased metabolic demands. Certainly, these both affect weight and health, but they do not both occur in all individuals, nor do they occur to the same degree in those whom they do affect. We also know from studying individuals with the same CFTR mutations that one CFTR mutation does not purely account for all of the symptoms they may experience. People with the same set of mutations may exhibit very different symptoms. Many of us have cared for siblings with the same set of mutations, but one may have severe GI problems with little lung disease, while the other sibling may have the reverse. Thus, it is important that nutritional care in CF is personalized. Nutrition research can help advance our knowledge from studying different groups of people, but care should always be individualized. As an example, we often hear that a child's weight should always be above the 50th percentile for optimal health. Here are BMI growth curves for two patients. The one on the left has a BMI well above the 50th percentile, while the one on the right is consistently below the 50th percentile. However, I can tell you that the person on the left is not healthier than the person on the right, and is in fact at risk for more health problems because of the high BMI. The person on the right has the appropriate nutrition for what they need, despite being below the 50th percentile. We have new opportunities and challenges in CF nutrition as we go forward. CFTR modulators are changing CF physiology for those that qualify and/or can obtain them. However, not everyone's body responds the same. Thus, we must be nimble and adaptive, continuously assessing the nutritional health of individuals. Like much of the world, CF is also seeing a boom in the number of individuals that are overweight and/or obese. Up to almost 1/3 of those with CF are reported to be overweight or obese. And this is not just in those individuals who are pancreatic sufficient, but also affects those that are considered exocrine pancreatic insufficient as well. The causes are multifactorial, but this is a very important area that we need to further understand and address in CF. And I would argue that we need to move away from a widespread culture that more calories are better, and it doesn't matter the source of those calories. We need to use nutrition research as a guide, rather than a strict set of instructions. Our laboratory is engaged in nutrition research by trying to improve digestion and absorption of nutrients by improving intestinal pH. pH is influenced by the presence or absence of acid and/or bicarbonate ions. We study how bicarbonate ions move in and out of cells in CF and try to identify ways to correct it when it goes wrong. CFTR is an ion channel that helps move chloride and bicarbonate in and out of cells. Bicarbonate, think of baking soda, is important in the intestine and pancreas because it neutralizes the very acidic stomach contents that are present in the intestine. This neutralization is important for the digestion and absorption of nutrients in the intestine. Also, a key focus of our research is to identify treatments that are CFTR mutation agnostic, meaning they would work for all CF patients, regardless of their mutations. While we are learning that the existing CFTR modulators may help more individuals than we originally thought, new research by ourselves and others are showing that non-white CF individuals are less likely to be helped by the current set of modulators. Thus, it is important to seek solutions for all individuals with CF. I mentioned that an optimal intestinal pH is important for good nutrition. This is accomplished through a balance in the amount of acid, shown here as H+, and bicarbonate, shown as HCO3-. In the cells, there are different ion channels and transporters, like those shown here, that move acid or bicarbonate in or out of the cell. Our laboratory focuses on how a set of chloride bicarbonate exchangers, termed DRA and PAT1, work in CF where you don't have adequate CFTR protein expression or function. Using CFTR knockout mice, which means that these mice have no CFTR protein, it has previously been shown that they cannot produce normal amounts of intestinal bicarbonate to neutralize stomach acid. Here in the black bar, you have the normal amount of intestinal bicarbonate produced by a healthy non-CF mouse. And here in the white bar, you have the response from a group of CF mice. As you can see, the CF mice can't produce a normal bicarbonate response. However, we were able to identify that a peptide or small protein named STA, which is made by the bacteria E. coli, can stimulate normal amounts of intestinal bicarbonate secretion in CFTR knockout mice as in healthy non-CF mice. Here you can see that the gray bars from both sets of these mice are similar in size. When we repeated the same experiments with the removal of chloride, which is required for chloride bicarbonate exchangers to work, the CF mice were no longer able to produce this bicarbonate response, as shown by the decrease in the gray bar. These results indicate that in CF mice, they use chloride bicarbonate exchangers to move bicarbonate in and out of the cell when there is no CFTR present. So we have been researching whether this peptide can improve defective bicarbonate secretion in CF patients in the intestines, and whether or not targeting these chloride bicarbonate exchangers could be a potential new way to improve deficient intestinal bicarbonate secretion in CF patients, regardless of their CFTR mutation, since these exchangers are not working with CFTR. Here's an example of some of the methods we use. We obtain small human intestinal tissue samples from people undergoing endoscopy, which is a procedure used to evaluate gastrointestinal health. We take the small pieces of tissue, a few millimeters in size, and we can grow them in the lab as a collection of cells called organoids. We can grow these cells in a way in which they mimic or look like what the original tissue looked like. Normal intestinal tissue has a collection of different cells along what we call the crypt-villus axis, and that's what make up these finger-like projections in the intestines. The crypt region corresponds to the bottom of this axis, while a villus is at the top. When we grow these organoids, they have the same different cell types that are found in the intestine tissue, except we can grow them for long periods of time. This allows us to use one set of tissues to do many different experiments. Using these organoids, we have been able to examine the location of different acid and bicarbonate transporters along these finger-like projections. In this set of experiments, we have produced different clusters of cells that correspond to different regions of the crypt-villus axis. The ones at the very bottom are labeled as 0 and are indicated by the gray bars on the far left. The very top region is indicated by 5 and is represented by the gray bars at the far right. The regions in between are labeled 1 through 4 and correspond to these regions on the axis. Here you can see that the transporters are not all expressed in the same set of cells. The acid transporter, NHE3, and one of the chloride bicarbonate exchangers, DRA, are expressed predominantly in the top region, while CFTR and another chloride bicarbonate exchanger, PAT1, are present in different regions along the crypt-villus axis. This information can help us learn how these transporters work and what cells we need to target for potential therapies. So we can take these organoids from people without CF or those with CF, or we can also make CF organoids using healthy tissue and a technique called CRISPR-Cas9 genetic editing. We can get rid of all or nearly all of the CFTR in the cells. We then use this tissue or these organoids in a variety of experiments. We can do immunofluorescence, where we can label these proteins and see where they are located in the intestine. We can do sequencing studies so that we can see where they are expressed and what cells we need to target. And importantly, We can do functional experiments where we can monitor the movement of chloride and bicarbonate in similar ways as I showed you previously with the mouse experiments. However, unlike the mouse experiments, this allows us to do it with human tissue so that we can see if the STA peptide will be beneficial to humans with CF, not just mice. Through all of these different types of experiments, we can determine if STA or other similar peptides can improve intestinal bicarbonate secretion in humans, and if so, identify the mechanism whereby it does so. This will allow us to identify potential new drug targets that can be used to restore defective intestinal bicarbonate secretion in human CF patients, regardless of their CFTR mutation, and ultimately help the digestion and absorption of nutrients in CF patients. So in summary, inadequate nutrition is key to many of the problems we see in CF, and optimizing it is important in CF health. While we often talk about nutrition and lung health as if it is a simple relationship, it is not. There is not a one-size-fits-all recipe, and CF nutritional therapy must be individualized. There are many new areas of research aimed at helping improve nutrition in CF, and I have shown you one example about how our lab is engaged in this type of research. Thank you for your attention today. Here are the people in my research group and how I can be reached should you have further questions beyond our Q&A today. Thank you.
Melissa, you're on mute.
I'm so sorry. It's only been a year. So as I was saying, Dr. Sellers, it looks like you have a lot of bicarbonate fans out there. Just wanted you to know that. So our first question is, based on what we now know about individualized nutrition therapies, what does that mean for the very earliest nutrition for babies diagnosed with CF?
Yeah, it's a very good question. And in fact, we've known for many years now that we need to be highly attentive to nutrition from the very earliest time of diagnosis. And that's in fact why it's been important to integrate newborn screening into for those individuals that may be at risk for CF. And so as soon as we have an understanding that someone has CF or concern for CF, it's important that dietitians and ideally gastroenterologists as well work together with pulmonologists and families to ensure that that child is obtaining the best and most appropriate nutrition early on. And again, as I pointed out, that doesn't necessarily mean that all CF babies have to be fat, but we need to ensure that they do have adequate nutrition, because especially early on, there's a lot of development that is still occurring, and we want to optimize that for them.
Okay, thank you. Next question that we got is, what is the relationship, sorry, that's my dog. What is the relationship between diet and inflammation? Do people with CF need to follow an anti-inflammatory diet?
Also a very good question. So there's been a lot of evidence outside of CF that diet is interlinked with inflammation in various organs throughout the body. However, it's not so simple as it is often made to seem. And in fact, even though we've realized this linkage for many years, there's still a lot of research and work going on to understand what is the ideal diet. We know that diet affects our microbiome. We know that our microbiome affects not just intestinal health and inflammation, but also inflammation throughout other organs itself. And so, you know, I think that we have to be cognizant of the fact that the nutrients that we put into our body is going to affect how our body works, and that does involve inflammation. We don't recognize and refer people to say that they should do like a Mediterranean diet all across the board, or those that have been touted in the non-CF world as being anti-inflammatory. But I think we need to give a lot more thoughts to the types of fats that we eat and the different types of foods that we eat, and that I think we can work closely with our dietitians and, again, our gastroenterologists ideally to identify what may be the best source of nutrients for each individual, so that you can gain the adequate weight and the right types of weight, right? Not just fat, we want muscle and all different types of good weight, so that, everyone can be as healthy as possible. As a pediatric gastroenterologist, I'm trying to set up my patients to live very long lives and be healthy as adults, not just as children.
Thank you for that. This is a question near and dear to me also. How are nutrition demands different for people who are pancreatic sufficient?
Yeah, I would even back up and say that, our nutritional requirements are not just broken into two groups, those that are pancreatic sufficient and those that are insufficient, but actually it's a big spectrum. And that's why, I say it needs to be individualized. Not everyone that is pancreatic insufficient should be treated the same. In just the same way, not everyone that's pancreatic sufficient should be treated the same. Now, there are some kind of broad strokes that we can think about. Those that do not have, don't make sufficient enzymes and or pancreatic bicarbonate to take care of nutrient digestion and absorption of nutrients themselves and need supplements, may have some different nutritional needs than those that can do that themselves and don't need those supplements. But I think that that's, again, where you work closely with your care team and look at your diet and your intake. And it's not just intake, as we talk about nutrition, right? There's a whole set of, exercise and activity also is linked together with our health and our nutrition. And so I think that I wouldn't approach it just in buckets, but rather say, okay, these are the foods that I think help make me healthy, and work with your team to identify what is the right sort of dietary recommendations you need, regardless of where you are on that spectrum of pancreatic health.
Thank you. How do you get nutritionists and our dietitians at our CF centers to focus on individualized nutrition?
Yeah, I would say that, it's easy to say that everyone should give a lot of attention to every single patient that comes in, and but there are realities of medicine and how medicine is delivered. And medical care is delivered, and not every center has all the same resources, right? There are very large centers and there are very, very small centers. And so I think you have to work with your team the best you can. And I think part of it is all of us first being on the same page that this is not a one size fits all thing, and that we need to think at least individually, but our dietitians and ourselves as gastroenterologists are used to looking at growth curves, individualized sort of growth curves, talking with their patients about their nutritional intake, their activity levels. And so that's part of our routine workflow anyways. I think that that you just want to make sure that as you're going into your visits, that you're making sure that you have enough face time and actually have time for these conversations, that as we have more things that we're screening for during our visits, we tend to be doing during our CF visits, many more screening tests, trying to tackle many more problems that we're learning about, and that creates time challenges. And so sometimes we just need to take a pause, both as patients, families, and also medical care providers, and say, okay, what do we need to focus on today? And what can we continue to talk about later in future visits? So it really is working together as a team and that sort of collaborative effort.
Yeah, thank you. It seems our appointments need to start getting even longer these days as we find out more and more things. Someone asked, how would patients increase their bicarbonate?
Yeah, that's something that obviously our laboratory is very interested in. In vitro or in cells outside of the body, we can just add some bicarbonate, sort of baking soda, the type of things, and see that things change. But that's not, and people have tried to do that in a more like in vivo or in humans, but that doesn't work well because your body has adaptive mechanisms to take part of that. My personal opinion in our laboratory's approach has been that the best way to do that is to understand how our body actually makes and moves bicarbonate, and then take advantage of those intrinsic mechanisms and target those rather than to exogenously give bicarbonate. And we actually learned many decades ago with therapies on stomach acid, so if you give something like Tums or Rolaids, which is essentially, bicarbonate, it gives you short-term relief of that acid in your stomach, but your body adapts and it will actually make more acid because it's trying to have sufficient amount of acid in there. So what our laboratory is trying to do again is sort of target the specific areas of the intestine which we need that bicarbonate, and not just apply bicarbonate everywhere.
I think we have time for one more question, but just for the viewers, we are having a panel with all three speakers at the end for more questions. So can people who are pancreatic sufficient become pancreatic insufficient later in life? And if so, why?
Yes, pancreatic health is very dynamic, and both occurs. People that are pancreatic sufficient through ongoing mechanisms of inflammation in the pancreas and such can become pancreatic insufficient. Likewise, we're seeing that those that have been thought to be pancreatic insufficient can actually become pancreatic sufficient. And we've seen that with some of the CFTR modulators. So one of the things that I always preach is that we need to be continually thinking about pancreatic health throughout one's life, not just being labeled once you're diagnosed as a child or whenever your diagnosis is as a one-time diagnosis. We should be continually evaluating how your pancreas is doing.
Okay, thank you so much. And like I said, we're going to bring Dr. Sellers back at the end.
And I'll be looking at the Q&A section for the questions and answering some there as well.
Exactly. Okay, thank you. Next, I'm going to introduce Dr. Virginia Stallings. She is a professor of pediatrics at the University of Pennsylvania Perelman School of Medicine, director of the Nutrition Center and the Jean A. Kortner Endowed Chair in Gastroenterology and Nutrition at Children's Hospital of Philadelphia. Her research interests include pediatric clinical nutrition, evaluation of nutritional status, dietary intake and energy expenditure, and nutrition-related chronic disease. Much of her clinical care, research, and advocacy are with infants, children, and young adults living with cystic fibrosis. And this is your second panel at ResearchCon, so thank you for joining us today too.
Very good. Thank you, Melissa, and enjoyed hearing Zach's presentation and agree that bicarbonate is an underappreciated part of CF, and glad to hear that there are going to be some advances. As Melissa said, this is my first ResearchCon, but I got to participate in another group session on Thursday. And I was delighted to be able to come back to this particular nutrition roundtable that was going to focus on research to tell you a little bit about work we've been doing really over the last 10 years that's resulted in a new medical food. So that's what I'll be talking about. I wanted to share these disclosures. The actual research I'm presenting today was funded by the NIH, but also to mention that after the study was over, I was involved in helping establish a small company to try to bring this product, which is now called Incala, into clinical care. So I continue to be a consultant there. So the idea that we now, I think as the whole care team, definitely recognize that nutritional status, growth in children, body composition, both having healthy amounts of muscle and fat do improve outcomes with patients with CF. And much of this came from epidemiological data, but I feel like after really about 20 years of exploring this, that we have solid evidence that these are related. Now, when I think about it today, and I show you here a table that I put together looking at data from 2004 up until the last we have from the patient registry, we have made huge advances. And you look at the top line, looking at weight at a pretty low cut point. We've gone from 20% of people being underweight using that metric to about 10. Looking at height and growth and stature being very important in CF, we've gone from about 15% to about 10. Now, part of how this has happened over these 15 years is many advances in care. But in this time span, most of this is not really related to the modulator therapies because of when they started and the specific mutations. What I wanted to bring up is a lot of this is supported by the fact that the GI docs, the dietitians, and the whole care team have gotten very good at trying to use supplemental feeding with a feeding tube. And over the years, we see across the whole US at any one time, about 10% of our patients require tube feeding. And then in addition to that, we have a good understanding of being able to use oral supplements and behavioral guidance to get people to eat more. And I put that under the category of supplemental feeding by oral, but that's about another 45%. So when you look at that, about half of the patients are actively involved in some nutrition support. And the truth is it's working. Patients are growing better. Thinking of adults, since we now monitor their BMI much better and have some guidelines around that, you can see about half of the adults have met their BMI goals and about half hadn't. And lastly, to mention that CF-related diabetes is also a component of our clinical care spectrum now as our patients live to older and older ages. So when you think about nutrition therapy and CF, I put it into these kind of categories. The biggest issue is the pancreatic insufficiency, and that's the fat-based malabsorption. The lack of the bicarbonate that you just heard about, the lack of the lipase enzyme. That results in growth faltering in children and infants, but it also contributes to the disease-related weight loss in both children and adults. Now we are also, again, trying to get better and better at having nutritional support that specifically goes to lung and potentially even liver transplant care in our patients, the general liver disease, and as I mentioned, the CF diabetes. So to start the focus of what my research effort has really been on is that even though we do have very good pancreatic enzyme replacement medicines, it's well established that doing that the best you can, you still have persistent fat malabsorption in patients with CF and pancreatic insufficiency. So what I'm, in response to that, Dr. Yerser, who's actually the inventor of this particular concept, which was to put together a structured lipid matrix. In my studies, it was called Limixorb. So you'll see the LXS abbreviation. Excuse me, and now the clinically available product is called Encalum. And it's really based on an important molecule, isophosphatidylcholine, and that it has some very strong characteristics that improve fat absorption. So this is how the product came to be and how the science really has evolved. The clinical trial was at CHOP. And again, the main component of this is that it is both lipase, the fat digestive enzyme, and bile acid, which are the little molecules needed to help make fat absorption efficient, are not needed to help digest and absorb the fat calories from this medical food. So the clinical trial itself had over 100 patients, children and adolescents who had CF and PI. And the finding from the really big part of the study was that their fat absorption, when they were randomized to either using the medical food or a placebo, improved significantly from the 82% to 88%. And a number of other outcomes improved as well. And to mention that our volunteers came from 10 different CF centers, and we were certainly very grateful for that. The work I've been doing on this in the last couple of years goes to questions that came to us about the spectrum of response, and the question to look at those who had more severe malabsorption at baseline and to see if they had a better response to treatment with the medical food. And you can see the citations for this collection of work. So the secondary analysis, I really focused on looking at just the changes between baseline and 3 months. And again, mentioned the children when they enrolled were 5 to 17 years of age. I want to mention that the placebo, instead of being a fake supplement or you often think of sugar pill kinds of things, this was a very active placebo, and it actually contained the same number of calories and fat as the medical food. So in this analysis, we wanted to look at those things from a nutrition point of view that are often considered some of the most important clinically and informative. So we followed weight and height, certainly BMI. We looked at the fatty acids that had been absorbed in the blood. And then of course, we continued to look at fat absorption in the stool. And this is that collection of the stool over 3 days. In the analysis, we took all of the potential subjects that we were going to look at and divided them into those that had persistent low fat malabsorption at baseline. And those are the ones you see here in red. And we used the cut point of 88% because that was the median of all of the patients. So now we're going to really just focus on the group with the low fat absorption. And I'll show a couple of data slides, again, just going back to the components of the outcomes that we were most interested in from the nutrition point of view. And in this first slide, you see the summary of the fat absorption. On the left-hand panel, this is all of the patients, that full group of 110. And at baseline, you see there was really no difference between the two groups. The placebo is in light blue and the medical food is in dark blue. And so randomization worked. At the beginning of the study, both groups were quite similar. At 3 months now, you can see where the medical food group has increased to 88%, and it was certainly statistically significant. And I had mentioned that before. So the new analysis here, looking at the group that had the highest need because their baseline fat malabsorption was higher. This is the panel on the right. You can see that the placebo group was at 73 and the encalor group was at 79 at the beginning. And those numbers are a little bit more different, but statistically we're not different. And then over the 3-month follow-up, you see where the placebo group remained quite low, now 71%, whereas the medical food group went up to 86% and again was statistically significant. And just to remind you that all of the patients did have pancreatic insufficiency, and they were all on enzyme therapy, and that enzyme therapy was being actively managed by their home CF center and through usual standards of care. So here in summary, the fat malabsorption was much better when using medical food. Now, one of my big focuses for my whole research career has really been about growth and how do we improve growth? How do we improve, if you will, growth velocity when we need our patients to have catch-up growth because they might have gotten a little behind. So this is showing you the data from the 3-month highest need patients. And I've switched to Z-scores rather than just percentiles that you'd be more familiar with on the growth chart. But if you look at the top row, you see WAZ, which is just asking the question about how was their weight at baseline and at 3 months, and did it change? And the delta column shows you that, yes, it did change. It went up 0.17 z-scores, and that was highly significant, which means that they're gaining weight at an increased rate or velocity. You see the same thing with the height, that over the 3-month period, the height increased 0.06, again, very statistically significant. And again, to have a measurable change in height in only 3 months does indicate that they had what we would call a growth spurt or catch-up growth. And if you increase weight and height, then you really do help normalize the BMI z-score. And you can see again that increased, and that was statistically significant. So in summary, we had very good indication of growth in the group that was being treated. The next area is to look at fatty acids. And fatty acids are important and very basic to our diet. Almost all of the fat that we eat comes in as triglycerides or little clusters of fatty acids, and then it's digested in the intestines and then absorbed into the blood, where there you see them as individual identifiable fatty acids. And there are probably 20 or 25 of those fatty acids that we see in the human blood. There are two that are particularly important, and they're called the 2 essential fatty acids. And in the nutrition definition, that means that they really are essential for life. These are fatty acids that the body can't produce by moving around molecules, and they have to come from the diet. And those are the linoleic acid you see here on the left and the alpha linolenic acid in the middle. I added another one, the gamma linolenic acid, because that's one that's sometimes associated with improved inflammation. So as you see here now, the placebo is shown in the yellow and the medical food in blue. And in each of those fatty acids, you see an increase. In the linoleic acid, 20%, the ALA really over 50%, and the GLA as well. So to mention that, because the way that the medical food was designed, it actually contains these 2 specific essential fatty acids. That was part of the inventor's plan. And I just show here in the bottom, based on if you're taking 1 or 2 or 3 doses of the Encala, how much contribution that would make to the recommendations of your daily intake. And I just used as an example, a 9 to 13-year-old female requires 10 grams, and a male young adult 17 grams. So you can see that these would be making a good contribution to the day in and day out needs. And lastly, I wanted to show you some of the information from the choline part of the study. And the medical food, as I mentioned, that LPC, the C part of it is choline. And we don't talk much about choline in CF care, although I think, we may be doing more of that in the future. But it's, again, an essential nutrient. It's a part of every cell membrane in the body, some of the neurotransmitters, and some other very specialized metabolism. So if you have a choline deficiency, what do you see? Well, increased liver enzymes, development of fatty liver or hepatic steatosis, which we know has long-term consequences. And also it changes the ability of the body to take those essential fatty acids to the peripheral tissue, like the muscles. So that's where you get some of the muscle abnormalities. And again, can affect neurotransmitters because of the unique acetylcholine compound. So what do we know in CF? Well, much of this it should be credited to the work that Sheila Ennis did, who was in British Columbia. And in her work, she went on to show early on that children with CF have low choline compounds in their blood. And this was even compared to their healthy siblings, which means they were basically eating much of the same food, living in the same environment. And there was even more separation, the more severe the CF. Then she compared the choline status of children with CF to those healthy children, and again, so it was much lower. And then went on to show in a very well-designed pilot study that if you supplemented choline, that people with CF, their blood levels got increased. And you also saw some of these other metabolic pathways normalizing. So to bring this forward in the original study, the LXS, you can see on the bottom line, the choline in milligrams per dose for 1, 2, and 3 doses compared with placebo. And just to mention, in the now clinically available product, it has about the same amount of choline, even though the dose size has gone down, which makes it a little easier to take. So the new product remains very choline rich. And what did we see? Well, when we looked at our patient group, and this was, again, the whole 110 subjects, that we found that low choline status was prevalent. About 45% of our volunteers had low choline. And that once they were treated with this choline-rich product, the choline in the blood went up. Many of the other metabolites related to choline were corrected only in the treatment group. And we also saw improvement in absorption, which we could tell by measuring how much of the choline byproducts came out in the stool. One of the other things that we were interested in is doing a special scan, an MRS scan of the calf muscle, of the big muscle in the lower leg. And because, again, choline is so related to both liver and muscle health, we wanted to check on this. And again, here we found at the tissue level that the calf muscle had depleted choline. There was less of it than compared to healthy people. And that after treatment, the calf muscle choline increased. And in fact, it increased up into the range of normal, healthy children. So now to come back to all of this, really our work started because we were interested particularly in pancreatic-based fat malabsorption. And just, I always put CF at the top of the list, but there are a number of other diseases in which pancreatic dysfunction contributes to the malnutrition. The other thing that we are now looking at and have thought about with this, there are a number of other conditions where the fat malabsorption is not related to the pancreas. But in fact, in 3 of those categories, it also overlaps with CF. So certainly in CF, we have a real interest in those patients that do develop CF-related liver disease and thus have bile acid depletion. We have a small number, but a real number of patients who have short gut syndrome because they've had to have operations on their intestines for a variety of reasons, which again makes absorption more difficult. And we know that patients with CF, there's a subgroup who really do have motility disorders, which can affect how your food moves through your intestine and how well you can absorb it. So to summarize all of this, there is now a new structured lipid nutrition therapy with published safety and efficacy evidence. And it was obtained in sort of our gold standard study. It was a randomized placebo-controlled blinded study conducted in people with CF and pancreatic insufficiency. The key mechanism of all of this is that the fat contained in the product can be digested and absorbed without the need of lipase and bile acids. So in effect, it works as its own micelle. And then lastly, from the study, we came out with excellent experience in the treatment in CF using the powder both orally and mixed with a number of foods that the patient would choose, foods and beverages, and also some experience using this with 2 feeding regimens, which, as we know, are a part of nutrition therapy here. So the CF Center dietitians over the last few months have been receiving information about the new medical food, and they will be a wonderful resource to find out more about this for patient care for adults and children. So thank you. Just to mention, this work has gone on for a number of years and certainly has involved many of our faculty, many of whom now are working around the country and around the world, and very grateful for that. So thank you, and Melissa, happy to take questions if we have some.
Yes, we do. Thank you, Dr. Stallings. So the first question, is there a choline-rich product we can take now?
Well, this is available now, and also the choline, you can get choline powder, that kind of thing, from health food stores. But you would need to really work with your dietitian to be sure that it was a product that had good quality and safety and help you pick out the dose. With this, the dose sort of goes along with what with what you need by age and dose. But yes, for sure.
To stick with the theme, are you planning on looking at whether supplementation with choline or other important fatty acids could be useful in children or adults that do not otherwise need supplemental feedings to maintain BMI?
Yes, I think when I now think about this, again, having been worked on it for a number of years, and currently it's recommended for use from about 1 year of age through adults. And we felt like there was sufficient experience with what we did. I know the company is working on some questions about dosing for infants and toddlers. So that's coming along. But even, as Zach and I both are talking about, starting at the very beginning of diagnosis of CF, and now fortunately most often with newborn screening, if you look at the data, children are often a little underweight. Possibly their stature is a little low too. But you wouldn't put a tube in, and you wouldn't start maybe really aggressive things. But I think this is a place we could also start to think about something like this using to prevent further malnutrition. And for it to be a way, and this goes into what we're all trying to think about, is more individualized diets, healthier. This is a product, it's plant-based. It's actually made from a derivative of soy. It's much healthier for the human body than MCT oils. So as we start to learn more about this and work with the dietitians, it may be something that could be used in small amounts to help maintain growth velocity without ever having to have the diagnosis of malnutrition or getting near using a tube feed.
Okay, thanks. Is this study applicable to adults?
Yes, I can say that very comfortably. We enrolled people up to 17 or 18 and then followed them for a year to a year and a half. And the dose that they took would be a similar dose we recommend for adults of all ages. So definitely can go forward with that. My only limitation right now would be babies, children less than a year. And I think that will be addressed by other people, in the coming year.
Oh, wow, okay. Something to look forward to. And could this product replace enzymes?
Okay, really good question. The straightforward answer is no, okay? The Incala helps its own self be absorbed, and it seems to make absorption a little bit better in general. But people who are pancreatic insufficient must continue to take their enzymes because it's helping digest all that other food in the meal. In my study group, we weren't in charge of enzyme dosing. That was the home CF center and the family and the patient. Mm-hmm. We did notice that they went down a little bit, and we think that's because people reported their GI symptoms were better, and they were feeling better, and they were, that kind of thing. And often that's when families will say, well, I'm not going to add that one more enzyme. But that's completely anecdotal. But the main thing you have to know is this: in patients who are pancreatic insufficient, does not in any way replace enzymes. It may help pancreatic sufficient. We've talked before about some GI problems, even in people who are pancreatic sufficient and don't have to do enzymes. So it would be worth trying there too, but critically important to maintain enzymes.
Yes, thank you. Okay, I think this is our last question, and then we'll be bringing Dr. Stallings back as well. Could this help lead to less liver disease?
Well, you know, that's a really good question. And we, in my study, having serious liver disease would have meant you couldn't be in the study. It would have been an exclusion criteria because we were really trying to focus. But one of the things we're very interested in doing is trying this in people with CF who have early signs, that often just the elevated liver enzymes or the early indication of that excess fat stores in the liver. Because choline is very related to, like I said, to fatty liver in its deficiency state. So we're hoping we'll be able to have another study relatively soon that would address that. Most of the CF liver disease, I think of it, have been like 10 or 12% of our population. So it's a rare complication, but very well described. And Jack and I both have people in our divisions who are really interested in the liver more than the pancreas, and we really hope to get everybody started on that. So more news soon. Thank you.
Okay, great. Well, that's a perfect place to end this right now. As I said, we are bringing Dr. Stallings back for a Q&A at the end. So keep typing in your questions. I saw there were a lot of pancreas questions, and Dr. Sellers has been diligently answering them. So please go back to the Q&A to look for those as well. Okay, for our third presenter and last, we have Dr. Alexandra Kass. Dr. Kass is a third-year pediatric pulmonary fellow at Boston Children's Hospital. She is currently investigating body image and disordered eating in adolescents and young adults with cystic fibrosis, as well as studying ways to improve clinician awareness and education about this topic. So important. Thank you so much, Dr. Kass.
Thank you so much for having me. I'm just going to share this. Okay. So thank you so much for the introduction, Melissa, and thanks to the organizers for inviting me to present and for everyone here today for joining. So I'm going to be talking about my research related to body image disturbance and disordered eating in adolescents and young adults with cystic fibrosis. I don't have any disclosures. So first, I'm going to discuss the background and why this is an important topic. Then I'm going to talk about the 2 surveys that I've distributed this year. So as we've heard, pancreatic insufficiency is common, and we all know that nutrition is an integral part of CF care, and there's a focus on weight gain as good nutrition has been associated with improved pulmonary outcomes. So because of this, there is this emphasis on nutritional care, and it's recommended that patients see dietitians at least once a year. So the majority of patients with CF are pancreatic insufficient and require enzyme supplementation with food intake. And pancreatic insufficiency necessitates that people take enzyme supplementation in order to absorb fat in their diet. And without enzymes, individuals would be unable to absorb the dietary fat they consume, which would result in GI distress, constipation, and weight loss. So this pancreatic insufficiency combined with baseline high energy demand from underlying breathing difficulties necessitates that people with CF consume a high calorie and high fat diet in order to maintain a healthy weight. So because of this, maintaining an appropriate weight is a major focus of CF care, as increased BMI is associated with improved lung function and better overall outcomes. So in addition to the CF specific concerns about weight gain, for decades, our society has promoted an unhealthy body ideal. The increased usage of smartphones and social media has caused adolescents and young adults to be constantly bombarded with unrealistic, unachievable, and unhealthy messages about what they should aspire their body to look like. And increased social media use has even been associated with increased risk of disordered eating in adolescent girls. So as with other chronic illnesses, there are higher rates of mental health issues in patients with CF. So per the most recent CF Foundation patient registry, 16.7% have depression compared to the general population where 7.1% have depression. So the high rates of mental health issues in CF patients, combined with the focus on weight gain from an early age, as well as the societal pressures to remain thin, make disordered eating a real concern in the CF population. And this is the basis of my project and why my team and I decided to further investigate it. There has been some work related to this topic that has already been investigated. As the pulmonary manifestations of CF tend to not present until later in life, weight gain is really the major focus of CF care as an infant and young child, and providers and patients carefully monitor weight gain and stooling pattern. So parental concern for and control over diet can be problematic later in life, as it's been found that children of parents who are overly involved in diets can have abnormal eating patterns and higher rates of dissatisfaction with their bodies. And that's in the general population, not specific to CF. But this can be even more problematic in the CF population, as parents of children with CF report that their kids have more feeding and behavioral issues compared to non-CF controls. And additional work has found that adolescents with CF rate eating problems and digestive function as the most important problem affecting their quality of life. So we performed 2 separate surveys. One was administered to patients and one to providers. The goals of the patient survey were to assess the prevalence of disordered eating in adolescents and young adults with CF, and to determine if surveys used in the general population are able to effectively screen for disordered eating in CF patients. The goals of the provider survey were to understand providers' baseline knowledge of body image disturbance and disordered eating in adolescents and young adults with CF, to assess how frequently providers screen CF patients for these issues, and to ascertain what would be the most helpful way to increase providers' knowledge and screening practices. So for the patient survey, we asked participants to fill out 3 separate surveys. The first was the Eating Disorder Questionnaire, or the EDEQ, and this evaluates for anorexia, bulimia, and binge eating disorder. It's 28 questions, and it addresses several aspects of eating disorders with 4 subscales: the restraint, eating concern, shape concern, and weight concern. So the restraint subscale involves questions about restrictive and avoidant eating patterns, as well as dietary rules. And an example of a question there would be, have you been deliberately trying to limit the amount of food you eat to influence your shape or weight? The eating concern subscale involves questions about preoccupation with food and concern for losing control over eating. For example, have you had a definite fear of losing control over eating? The shape concern subscale involves questions about preoccupation and dissatisfaction with body shape and weight. For example, has your shape influenced how you think about yourself as a person? And the weight concern subscale involves questions about preoccupation with weight or shape and desire to lose weight. For example, have you had a strong desire to lose weight? And of note, this survey and the next one were not validated in the CF population, so having CF might skew the answers. The NIAS is a 9-question survey, and this evaluates for ARFID, or avoidant restrictive food intake disorder. And this was a newly characterized eating disorder, but it's an eating or feeding disturbance that is characterized by persistent failure to meet appropriate nutritional and/or energy needs. And there are 3 subscales in this survey: picky eating, appetite, and fear. So the picky eating subscale, an example of a question here, is I dislike most of the foods that other people eat. The appetite subscale, an example of a question here, is I'm not very interested in eating. I seem to have smaller appetite than other people. And the fear subscale, an example of a question here, is I eat small portions because I'm afraid of GI discomfort, choking, or vomiting. And then everyone here is probably more familiar with the CFQR, which evaluates 9 health-related quality of life domains, as well as 3 symptom scales. And we had participants fill out the entire survey, but for our analysis, focused on body image, eating disturbance, and weight subscales. And as I mentioned before, it's important to note that both the EDEQ and the NIAS, they're not validated in the CF population. So the answers to some of the questions might be confounded by the fact that people have CF. So patients might answer a specific way because of the CF diagnosis rather than any underlying eating disorder. And that's why we included the CFQR. We wanted to compare answers on the EDEQ and NIAS to the CFQR, as the CFQR is obviously validated in the CF population. So in terms of results, we did have 52 patients who enrolled in our study, and they ranged in age from 14 to 35 years with a mean age of 24 years. There were 19 males and 32 females. In terms of mutation, there were 30 patients who were homozygous for Delta F508, 16 were heterozygous, and 6 had other mutations. And the majority, so 46 out of 52, were on modulator therapies, and 45 of those 46 were on Trikafta. So these are results for the relevant subscales of the CFQR. The left column contains the means and standard deviation of our patient, and the right is the published mean and standard deviation for other studies that have been done. And the score on each of these subsets ranged from 0 to 100, and a higher score indicates a better quality of life. So you can see the scores in our participants are similar to maybe slightly higher than published data. So, in this area, we can say that participants are at least somewhat similar to the general population. Next, we'll look at the EDEQ. And in this survey, a higher score is more concerning for eating disorder. So as you can see, the average score for our participants were lower, so less likely, similar to lower, so less likely to have an eating disorder than published means of the general population. However, there were 5 patients, or about 10% of our participants, who screened positive for a clinically significant eating disorder, which is a fairly significant portion of the population. And in terms of general population, numbers vary, but it's about the same percentage in the general population. It's important to note, too, that of these 5 individuals, not all of them were very thin, but there was a range of BMI and included both a normal and high BMI. And then finally, on the NIAS, which again evaluates for ARFID, a higher score is more concerning for eating disorder. And as you can see here, the scores are again similar, though generally slightly lower than the general population, so slightly less concerning for a concerning eating pattern. And for this scale, there's actually no specific cutoff to diagnose ARFID. For our participants, there was a large range, so some people scored very low, some scored higher. For some patients, it is a concern, but obviously not for everyone. And it seems like our participants were, as I said, a bit lower than the general population. We only had 52 participants, so it's obviously hard to make broad statements, but at least these results don't indicate that individuals with CF as a group have more tendencies toward disordered eating than the general population. That being said, there was a fairly significant proportion of individuals who did qualify for eating disorder, which can have important consequences. And so we felt that this was, despite the average scores, this was still a very important issue and something that needs to be looked in further. So next, I will talk about the survey to providers. So there haven't been any studies evaluating CF providers' comfort with screening for disordered eating and body image disturbance in the CF population. So we surveyed the entire CF team through the CF Foundation. And this was a one-time survey that my research team and I created. It had 79 questions. And the survey assessed for baseline knowledge. It evaluated whether providers felt this was an important topic in the CF population. It investigated how comfortable providers felt screening and how often they screen. And finally, it explored different possible ways to improve training in this area. So we had 233 individuals participate in the study. 103 of these were pediatric providers, 66 were adult providers, and 83 cared for both. And here I have the breakdown of the different participants. The majority were physicians, who comprised about 40%, and there were majority pulmonologists, but also gastroenterologists and endocrinologists who participated in the study. The next most common was dietitians, who comprised about 20%, and then social workers, who comprised about 16%, and then other subspecialists also participated to a lesser extent. So in the survey, we asked providers how they felt about screening for each of the following: adherence to enzymes, adherence to insulin, food avoidance, food restriction, body image disturbance, selective or picky eating, purging, binge eating, and excessive exercise. And we found across the board that providers felt these were important or very important topics to discuss with their patients. However, not many felt comfortable or very comfortable screening for them, and even fewer often or always screened for them in their daily practices. So this is very interesting for us. Clearly, it's something that providers think is important, but don't feel comfortable with. And we just finished data collection and really just started data analysis. So this is all kind of fresh, but the next thing we're going to be doing is breaking this down by provider to see which type of providers feel this is more important, which are more comfortable, and which screen more or less often. Also interesting was that a significant majority of responders felt that the CF team specifically, so not say a primary care doctor, should be the one screening for eating disorders and body image disturbance, and that both of these should be standardized in CF care. But interestingly, only 2.7 participants used a formal screening tool to screen for these issues. So it's clearly a need for more information in this area. So our preliminary data analysis shows that a clinically significant number of CF patients screen positive for disordered eating, indicating that it is an important issue that we need to learn more about. While we do have excellent screeners for eating disorder in the general population, eating behaviors in those with CF may be different compared to the general population, and there aren't validated surveys in the CF population. So there is the potential to create this type of survey in the future. We did find that there was some correlation between the CFQR and the other two surveys, the EDEQ and NIAS, in kind of preliminary analysis, but we do need to look into that further. And then on the provider side of things, we can see that providers feel that disordered eating and body image disturbance is an important topic, especially with the introduction of Trikafta, with people gaining more weight. They think that it's kind of come up more. Most don't feel comfortable with screening for it, and even fewer address this with patients. And in terms of ways to improve teaching, they felt the best way to disseminate this information would be screening to providers through NACFC sessions, webinars through the CF Foundation, and guidelines for screening, and also close connections with eating disorder specialists. So this has been very interesting and very interesting topic for me to look into. And I really look forward to doing more investigation in this area in the future. I want to thank the Cystic Fibrosis Foundation for their extremely generous funding and support for this topic, and for inviting me to speak here today. I'd also like to thank my mentors, Greg Swicki and Tracy Richmond, as well as my research team, who I have mentioned here. And then a big thank you to the study participants who took the time to fill out the surveys. And now I'm happy to take any questions.
Thank you so much, Dr. Kass. I find that research so fascinating, and I look forward to see where it goes.
Yeah.
So as more and more people with CF take modulators and are gaining weight as a result, as you just talked about, how do you see the shift in conversation on nutrition? Some patients are gaining so much weight that they are now having to watch what they eat for the first time and are, dealing with these body image issues.
Yeah, so that's a really important and excellent question, and another reason that we thought this was an important time to look at this. I think it's just important to kind of keep the conversation going, and if you see someone who might be mentioning that their eating habits are changing, or might have gained a lot of weight or lost a lot of weight, to kind of bring up the topic and normalize it with them. I think it is important to have screeners to kind of alert providers to an issue, because we certainly don't want, with all the important advances that are happening with Trikafta, we don't want this to become a new issue. So I think just kind of having providers be aware of it and making it a topic that is regularly discussed will be important.
I have two questions that are kind of follow-ups and related to this.
Yeah.
About, getting your kid to eat. someone discusses their 13-year-old daughter has done really well with Trikafta and was able to get her G-tube removed. Amazing.
That is great.
She's struggling with not overeating. And all her life, she's been told to eat whatever she wanted and high-fat foods. And she's never looked this healthy. However, in her mind, she's fat. So do you see a lot of this in your teen patients, and what can we do to have our physicians dealing with this?
Yeah, I think that's been, I think, a concern that a lot of people have had. You know, people with CF are traditionally, it's not hard for them to be, they can eat everything, as you've mentioned, and be thin. And this is become, of course, Trikafta is wonderful, but this is becoming a new issue. And I think it's just important to have it be discussed with patients on, to have it really be introduced into the appointments and have it be kind of standardized in CF care. And I think, talking about the fact that people will gain weight before they start Trikafta is important, so that people are aware of it. As Zach mentioned, it's important to not just eat everything, but eat healthy. I think just, continuing that discussion of it's important to eat healthily and incorporating this into the regular discussion of CF care is important.
Right, and it sounds like from your survey, caregivers agree with you. It's just
right.
We got to get them to a place where they're comfortable dealing with
Exactly. And there were several factors, what I didn't report here, that made people less likely to screen, and most of it was just lack of comfort and just not knowing enough about it. We asked, could it be lack of time? Is it that a parent's in the room? But it's really that people just don't know enough and don't know, if they do find something, what to do about it. So I think that would be the worst thing, if you find an issue and then don't know how to help the person. So I think trying to improve that would be great as well.
Right. And then on the other side, somebody wrote, trying to get my teen to eat used to end in tears on both sides. How can we encourage adolescents to eat so that they get enough calories and fat and nutrients without creating food issues? Right.
I mean, that's an excellent question. I think, not just specific to CF. And I think just having, open on, conversation about nutrition, and again, just kind of normalizing it in care and bringing it up from an early age. And I think if you notice that there are concerns, bringing them up early and talking to your team about them, and trying to get appropriate referrals, because, it is so important to maintain a healthy weight and to eat healthy foods. And, we don't want that to lead to issues. It's a really good question. I don't think, unfortunately, we don't know all that much about it, so I don't have the best answers for it. But I think, as we're learning more, and I think we'll hopefully be able to form partnerships with eating disorder specialists, and we'll be able to have better guidelines, hopefully soon, that can better address the questions and concerns. But it is definitely a huge issue.
Right. And then last question. I wrote this one, but for a project that I mentioned earlier with another CF adult who is a dietitian. I learned that adolescent females with CF are more satisfied with being thin than their male counterparts, which didn't surprise me, but what surprised me was that the disordered eating, like withholding pancreatic enzymes, that was news to me. So I'm just wondering if with your study, we're relying on adolescents, self-attestation of their disordered eating, how can providers reliably treat eating disorders? Because I just feel like if they're doing that, they might not admit to it.
Right. And so the surveys that were for the general population, they've been validated. And of course, that's not just a concern in the CF population. So obviously there are going to be people who are not being totally honest on the survey because they don't want help. But I think really closely following weight, and, just talking to the patients. These are just surveys. So this is kind of just like the first way to get information on disordered eating, but, talking to your patients and following their weight, following other metrics is really important. And I think if there's any concern, even if the surveys, a person screens negative, it's important to further discuss it and talk about it. And I think that's why ultimately it's very important to have a good relationship with your CF team, and why it's important for doctors to feel comfortable, and dietitians, social workers, everyone should just feel comfortable talking to their patients, because we can't just rely on these screeners. Obviously, it's just kind of an introduction into it. But, yeah.
Thank you so much, Dr.
Yeah.
Kass.
Yeah.
I'd like to bring back Dr. Sellers and Dr. Stallings. And we'll have a group Q&A here. We have a lot of good questions. Hi, everyone. Okay, I'm going to start off with one that I see over and over again, and that is about BMI. It seems that the CFF BMI metrics impacts the way CF centers individually treat CF patients, since they are graded on their patients having a certain BMI. Dr. Sellers gave great information on why this is not optimal. Is there a movement at the CF Foundation for changing those BMI guidelines and moving away from BMI in general? And I would also just add to that, just the idea of BMI versus body composition.
So if you don't mind, I'll start a little bit with that, because with many other people, I was a part of establishing those recommendations now, a few years ago, over a decade ago. And I think the easy answer is yes, there is a movement. There's an awareness that was a good start, but we need to keep working on this. The foundation is certainly aware. The dietitians are advocating for this in many ways. And in our session a few days ago, we did actually spend a good bit of time on future directions, which we hope will include body composition, so that we can help learn about the proper amount of fat stores to stay healthy and optimizing muscle. So, this getting a collective evidence-based new set of guidelines takes a while, but I think everybody has heard that very nicely, and there's an agreement we really need to go back and take a look at this. So thank you for that. Yes, good.
If anyone else has anything to add, Dr. Sellers?
Yeah, I'd just add that I think that previously, we've thought about CF as a very sort of homogeneous sort of population, and for a variety of reasons, and in part because of our expansion of genetic testing, and then also more recently with CFTR modulators and how they differentially affect different populations of people, we're now seeing a much more diverse and larger spectrum of patients. So we don't have like a single or two buckets of sort of people as we've previously sort of thought of. And so I think that creates some new challenges and opportunities to think about how we look at the quality of care that we provide, and whether we're providing appropriate care in these types of reports. And I will say that, at least at our center, and I'm sure this occurs at many centers, is that when we get these reports and I sit down with my dietitian and our care team, and we individually discuss, the actual patients and see, how are we doing at a personal level? And I think, because at the end of the day, that's what this is all about, right? Is, how are the individual patients doing? So these quality metrics can be helpful to provide information to us, but at the end of the day, we have to take that back to the individuals. And I think there's an increased recognition that there is a large breadth of different types of disease, and we just need to, I think, do a little bit better at identifying the right metrics.
Yeah, thank you. And I'm so glad that nutrition and diet, more integrated nutrition, is being brought in here, because I feel like for some of us older patients growing up, a dietitian would walk into the hospital room and be like, eat fat and leave. And, it really didn't help much. So another question is, as long as I can remember having CF, calorie intake was the primary concern with particular emphasis on fat and salt. It seems like this has been changing. For instance, fast food is not discouraged, but there's more focus on a balanced diet. Can you explain when this changed and what prompted the change?
Well, again, all of you know that the salt issue is very historic, and it's part of the fundamental problem, and that we've had to learn over years how much do people really need a lot of extra salt. And many years ago, the answer was yes. Unfortunately, now there's so much salt in the food supply in the US, so that even for people with CF who have extra losses, that may not be necessary. I think as you've heard about the whole discussion here, over the last few years, the idea that CF was changing and we wanted to move from eat fat, any fat all the time to really a healthy food pattern. To bring it in our nutrition world, we talk about to the dietary guidelines. And we have the luxury of beginning to do that now because we have so much less malnutrition. Back at the point where getting particularly young children not to be so malnourished made them much more susceptible to lung disease and infection. So I think we're right on the mark, and I think we have to give the modulator drugs some credit here, because with ivacaftor, even in gating mutations, which is the best fit, drug, and the outcomes are better than anything. All of us on the non-pulmonary side were just ecstatic to see the weight gain. That's been out since about 2012. So timing, it's all coming together now, and it's our responsibility to, along with the CF Foundation and our patients and families. But I think it's at the top of the list, and it is going to take some adjustment, but I think we can get there. Fat's important. Healthy fat is important. People with CF will be eating more like their friends and peers.
Yeah, I would just add that care guidelines always trail the primary research, which may be obvious, but I think that we try and shorten that time lag as much as possible. But obviously we need to generate enough research in a diverse enough group of people before we sort of put forward guidelines. That being said, as I mentioned, guidelines are, we have to be careful with them, that we don't just broadly apply them to everyone without thinking about them. But I do agree with Dr. Stallings, right, that the way things have been going, I think we're in a positive direction, and I think culture is changing, and it's not everywhere, but I think together as providers and as patients and families, we can really advocate for that change to be broad.
There are so many more questions that I have personally and that I know everyone else has, but we're coming to a close, so I just want to let everyone know that this is the beginning of the conversation. We are going to be talking about this for a lot longer. So I want to thank everyone for presenting your work here today. I feel like I learned a lot, and I can tell by the chat flying that there's a lot of interest in these topics, so thank you. Before we close, I want to draw your attention to how you can be involved in upcoming projects about nutrition. Community Voice comprises people from across the CF community to bring their unique insights and priorities to the forefront of research, care, and programs. When you join Community Voice, you receive tailored opportunities catered to your interests, from surveys to joining committees that you can do from the comfort of your own home. Community Voice is offering an upcoming project related to nutrition. The only way to get involved is to join Community Voice. You can join by visiting the web address or by texting the number that you see on the screen there. You can also find out more about Community Voice in the Community Resources tab on the events homepage. I personally have been part of Community Voice since the beginning. I love it. I've been able to participate in projects that I feel very passionate about, such as this, connect with people in the community, and have been able to share my experiences and expertise as an adult with CF in blogs, surveys, committees, and planning events like ResearchCon. As people with CF, caregivers, siblings, spouses, children, etc., our voice is vital to demonstrate what the needs of our community are. So I encourage you all to get involved. I want to thank again our speakers for sharing their knowledge and insight about CF and nutrition. And thanks to all of you out there for your attention and your questions. They were great questions.